I don't have any disclosures relevant to this presentation. So zanzalintinib is a mouthful, so I'm going to refer to it as Zanza, a next-generation TKI in RCC and other solid tumors. So this shows you the different processes that Zanza inhibits. So Zanza is a VEGFR TKI primarily, but also blocks other processes involved in angiogenesis, tumor progression, and tumor immunity, as you see here in this colored cartoon. So it is an orally bioavailable small molecule VEGFR TKI that was shown to inhibit MET, VEGFR2, AXL, MER receptors in vitro. Similar target profiles to cabozantinib, and you see here the IC50 values for both, Zanza biochemical and Zanza cell for these different receptors. Its PK profile, however, is interesting and differentiates it from cabozantinib. After a single dose, Zanza median Tmax was 1 to 6 hours for tablet formulation. At steady state, Zanza mean terminal half-life was 16 to 22 hours, in comparison to cabo, which has a terminal half-life of 99 hours. Zanza steady state was reached by day 8. So Zanza retains the target profile of cabo with an optimized PK profile. Interestingly, the introduction of a metabolic soft spot reduces its half-life in preclinical species and stability in the presence of human microsomes and hepatocytes. And importantly, Zanza has lower protein binding and altered tissue distribution versus cabozantinib. And I think this is the main one that differentiates it from cabo, and it leads to a more favorable safety profile than cabo. So here on this slide are the treatment schema study design of the Stellar 001 study, which is a phase 1b trial in 81 patients with multiple solid tumors, and they tested different doses of Zanza from 10 to 140 milligrams daily in patients with inoperable, locally advanced metastatic or recurrent solid tumor. And the recommended dose that they identified and selected for future studies is the 100 milligram daily dose. So in that study, they had an expansion cohort in 32 patients with clear cell RCC. Those patients had advanced metastatic or recurrent RCC with a clear cell histology. Sarcomatoid features were permitted, measurable disease per RECIST, ECOG performance status 0 or 1, and up to 3 prior lines of anti-cancer therapies. The primary endpoint was ORR and PFS at 6 months per RECIST. Secondary endpoint safety and exploratory endpoints PFS and duration of response by RECIST by investigator. And here on the slide are the baseline patient characteristics. I'd like to draw your attention to that 26 out of the 32 patients with clear cell RCC in this cohort, or 81%, had intermediate risk by IMDC. 31 of 32 patients, so 97%, had prior immune checkpoint inhibitors, and over 50%, 17 out of 32 patients, had prior cabo. So here are the responses. To the left, you see a waterfall plot. In blue are patients who had prior cabo, and you can see several of these had responded to Zanza after prior cabo. In green are patients who were cabo naive, and you see that the ORR in this 32 patient cohort was 38%. Disease control rate, defined by major response plus stable disease for at least 6 months, was 88%. Now, to your right, you see the bar graph of responses in patients who had prior VEGFR TKI exposure, and you can see an impressive 63% ORR in patients who had prior VEGFR TKI but not cabo. And disease control rate, of course, this is a small number of 8 patients only, was 100%. To the right of it are patients who had prior cabo, and disease control rate was 92%, and ORR was 35%. In patients who had prior cabo, but necessarily other VEGF TKI, those who had prior cabo, the response rate was still, in my opinion, relevant with 24% ORR and disease control rate 94%. So this is the spider plot for those patients who are cabo naive or cabo exposed. It's important to note that at a median follow-up of 8.3 months, 50% of the patients were continuing treatment. 75% of responses occurred at the first post-baseline tumor assessment, which was 8 weeks, including all responders who had prior cabo. So this is a busy slide, but the tornado plot to your right is typical of what we expect to see in patients treated with VEGF TKI. I think it's important to note that there were no treatment-related grade 4 or 5 AEs in this patient population. Now, I will skip this slide because this is obviously, we know there is a rationale for combining a VEGF TKI with an anti-PD-1 in RCC. And here is the Zanza clinical development program. You could see Stellar 303 is a phase 3 trial in advanced metastatic microsatellite stable colorectal cancer, testing Zanza plus Atezo versus regorafenib. And this is a completed trial, and the results are awaited. Stellar 304 is shown on this slide here. This is the treatment schema and study design. It's a 2-to-1 randomization of Zanza plus Nivo versus sunitinib in 291 patients with a non-clear cell. The histologies recruited to this trial are papillary, unclassified, and translocation. Primary endpoints PFS and ORR by BICR. Secondary endpoint OSS, and stratification is by risk, IMDC risk, and histological subtype. So this is a summary of my talk. Due to its Zanza, favorable characteristics and properties, I believe Zanza is a next-generation TKI building on cabozantinib key strength and aiming to deliver an improved benefit-risk profile for patients with RCC and other solid tumors. Thank you for your attention.